Okay, so I think we're going to skip over to Dr. Haroon. So just to introduce Dr. Haroon, the co-director of the Spondylitis program at Toronto Western Hospital. Actually, he's one of those maps. Dr. Haroon and I met at a medical conference in Lucknow in northern India. It turned out, besides our intrinsic attraction to ankylosing spondylitis, we really love dire straits. So we got into the car, we were driving around Lucknow, and Dr. Haroon puts on this tape of dire straits. I said, "Are you a Mark Knopfler fan?" I said, "We belong together." So Dr. Haroon came and did a PhD in Toronto, listening to dire straits in the lab most of the time, and has had a spectacular success and a huge contribution to spondylitis. Dr. Haroon.
Thank you very much for that kind of introduction. We're running a little bit late, so there are several data slides here. So I'm going to be talking about treatment of ankylosing spondylitis. What I've tried to do is try to concentrate more on the recent advances, because I know most of you have been coming year after year. So I've tried to do only recent advances, and then sort of leave with a few messages for you. Okay, so the goal of today's talk is to understand that there is a window of opportunity when treating ankylosing spondylitis patients. We have ACR's, the American College of Rheumatology has come up with recent recommendations. It's not yet published, but it was presented at a recent conference. So we'll just go through those recommendations to see what is new. We'll talk about the two major modalities of treatment, biologics, TNF inhibition, and IL-17 inhibition. We'll see the results. And finally, we'll stop with how we can modify this disease, what are the results, and approaches to do so. Okay, we'll start with a very simple slide here, right? Very easy to follow and understand. So the only thing which you want to be looking at is this box here, 81%. So that's the chance of responding to TNF inhibitor if you fall into this box. If you fall into this box, there's a 5% chance of responding to a TNF inhibitor. So now let's see what the characteristics of this box are. So they have low BAS-V score, which essentially means that they are more functional. Okay, they are much younger, and they have high markers of inflammation. They're likely to be HLA-B27, the gene. They're likely to be positive for that. Okay. So the most important thing which I want to mention from this is that they are much younger, and you could substitute this for the disease duration. So if you diagnose these patients with, say, less than 2 or 3 years of disease duration, you're much more likely to achieve remission with these drugs compared to somebody who was diagnosed at 10 years or later. Okay, and I'll just show you with couple of slides. These are the results from the original TNF inhibitor studies, and patients enrolled into these studies had around 15 years of disease on average. Okay, so these are the drugs which you're familiar with: infliximab, etanercept, adalimumab, golimumab. There is one more, certolizumab. All of them have almost similar results. And what is the result? A 40% improvement in symptoms at 6 months. Okay, 40% improvement in 6 months at 6 months in around 50% or less number of patients. So that's what the clinical trial shows from the original studies. Now let's compare that to this study. And if you look at any of the more recent studies, patients have been included at 3 years to 5 years of disease duration, and some even at 1.5 years. And just look at this column here. Partial remission, which means that you're essentially asymptomatic. It was very difficult to achieve a while ago in ankylosing spondylitis. So patients without any symptoms, more than 50%, and that too at 16 weeks of starting treatment. And the main difference is when the treatment was started, at 1 to 2 years versus 15 years. So clearly, the earlier you diagnose these patients and start treatment, the higher the likelihood of getting clinical remission. Now we move on to this study. This is a study with infliximab. Just as an example, this study was, the question we are asking in this study is, can we treat ankylosing spondylitis like we treat cancer? So come in strong initially rather than wait for a long period of time before starting the biologics. So these patients essentially had symptoms for less than 3 years. They had never even tried anti-inflammatory drugs. Okay, So they are randomized to 2 arms. Even before anti-inflammatories, they get infliximab straight away, a biologic, or they get an anti-inflammatory. And at 6 months, look how many people have gone into remission. And if they've gone into remission, then they're further randomized to, so the infliximab or the biologic is stopped there, and they're further randomized to receive either no treatment or they just continue on the anti-inflammatory. And further down, by end of 1 year, how many people are still in remission. So let's look at the first time point. You'll see here, 62% of people are in remission at 6 months with the biologic. Interestingly, 35% of people are in remission just on an anti-inflammatory. And this is quite close to what we have achieved even with a biologic in the previous studies. That shows that if you start early, even anti-inflammatories have a very good response rate, and much better if you start with a biologic. Okay? Now, what happens if these patients, you take off these drugs? Almost 50% of these patients remain in remission at the end of 1 year. So again, showing that if you diagnose these patients early, treat them aggressively, there is a higher chance of stopping the biologic at a future time point. So the chance of a drug-free remission is much higher if you diagnose and treat them early. Okay, so now we move on to the 2018 update of the American College of Rheumatology recommendations. So the main difference from the previous recommendation, which was, I believe, in the 2012-2013 period, is the addition of interleukin-17 inhibition. Okay, we'll come to that shortly. So if patients have active ankylosing spondylitis, whatever appears in green means strongly recommending favoring that treatment. Okay, whatever appears in red means you're strongly against that form of treatment. You'll see here anti-inflammatories. The first line of treatment is anti-inflammatories and physical therapy. Okay, what is in red? Steroids. So steroids may work for a short period of time, but you need very high doses, and you can't keep taking them forever. So it is strongly recommended against taking steroids like prednisone for a long period of time as a form of treatment for ankylosing spondylitis. But for a short period of time, if the situation demands, for example, in pregnancy, in the last phase of pregnancy, you cannot take anti-inflammatories, maybe that's a period when you can take a short period of steroids. There may be a few other such situations. Okay, if patients have significant peripheral joint involvement, maybe we could add sulfasalazine, methotrexate, some of the drugs which you're aware of, they're taken orally. They have not yet reached the biologic. And if there is significant pain, and if it is restricted just to a joint, for example, sacroiliac joint, you can try injecting steroid locally into that particular joint. Okay? Now, if you've tried anti-inflammatories, in our clinic, around 25 to 30% of people need only anti-inflammatories. And they respond to that, they just keep taking that, that's fine. But the remaining number of patients, they need something stronger. And then the first line of treatment recommended by the American College of Rheumatology is the TNF inhibitor, because of almost 20 years of experience with them. We know how safe they are, we know the side effect profile, and we know how to monitor them. So TNF inhibitors are usually the first line of treatment recommended. And if there is recurrent iritis, eye inflammation, or if there is inflammatory bowel disease, then specifically a monoclonal antibody is recommended. So there are 2 different kinds of TNF inhibitors, a monoclonal antibody and a receptor. So etanercept is a receptor, it has a different mechanism of action, it is not as effective for iritis and inflammatory bowel disease. So the other 4 are recommended if you have this particular condition and if it is active. Okay? If you still continue to have active ankylosing spondylitis, then you probably need to switch. Now, it depends on whether you responded to the first TNF inhibitor or not. If the patient has responded to the first TNF inhibitor, it means that the disease in that particular patient is likely TNF driven. So in that case, maybe we are losing the efficacy because the body is rejecting the TNF inhibitor that is being used. So maybe you can go to another TNF inhibitor. But if you start a TNF inhibitor and there is no response at all, then probably it is better to go to a different mechanism of action, that is the interleukin-17 inhibition. So TNF and interleukin-17, these are the 2 molecules that are currently considered to be important in driving inflammation in ankylosing spondylitis. So we have secukinumab, which is currently approved for treatment in ankylosing spondylitis, and that is the next step in treatment of ankylosing spondylitis. Okay, I think we can go on to, I already showed you the results of TNF inhibitors. Now I'll show you a few results of targeting interleukin-17. So we have several ways of targeting interleukin-17. So essentially, interleukin-17, there are different kinds of interleukin-17. They attach to the receptor for interleukin-17 and activates the immune cells in the body to create a lot of inflammation. So you're trying to block this interaction between the molecule and its receptor. You can do that either by blocking the molecule or by blocking the receptor. So secukinumab, which is currently in the market, blocks the molecule IL-17. Ixekizumab is the second molecule which has just been published in both biologic naive patients and also those who have failed a TNF inhibitor. I'll show you the results shortly. And then a third molecule which is approved for use in psoriasis and psoriatic arthritis is brodalumab, which actually blocks the receptor. So these are the two different mechanisms by which you can block interleukin-17. So for secukinumab, there are many studies that have been done on secukinumab, and they start with the term measure. I don't know why, but it's measure. So the measure 1 study, 2, 3, and 4 have been published so far. They're testing different situations. So measure 1 tested whether it's advantageous to have an intravenous loading dose. Measure 2 tested subcutaneous loading dose. Measure 3 tested if a higher dose of 300 milligram is beneficial than the currently approved dose of 150 milligram. And measure 4 tested without any loading dose at all. Okay, and this is in a nutshell what the results look like. They're almost similar to what you expect with a TNF inhibitor. So it's not that one is better than the other, almost similar results. It may be that in a particular patient, the disease is driven by TNF, then the TNF inhibitor is better for that patient. If it's driven by IL-17, then maybe IL-17 inhibitor is better. Unfortunately, we don't have a mechanism by which we can identify the best drug for that particular patient at baseline. So we're working on it. Hopefully, in the near future, we'll have some kind of algorithm in which we can do that, by which we can do that. Okay. This is the new drug, ixekizumab. Again, similar to secukinumab, blocking interleukin-17A. Two published studies so far, COAST-V and COAST-W. COAST-V is in patients who have never seen a biologic before, just straight after an anti-inflammatory. And COAST-W are people who have failed a TNF inhibitor. Interestingly, in this study, I think this is probably the first study where individuals who have failed even 2 TNF inhibitors were allowed into the study. So multiple TNF inhibitor failure yet allowed into the study, and the results are almost similar to what you would see with the secukinumab as well. There is a between 30 and 40% chance of responding by around 50% response in these patients, which is similar to what we have seen before. So these are the main results of the ixekizumab study. So here there are multiple arms in studying 80 milligram, 160 milligram, and the results are almost similar between the two doses. It was tried every 2 weeks and every 4 weeks. And this is just to show you the duration of the disease in this trial. It's not that different from the original TNF inhibitor studies, right? It's around 15 to 16 years of disease. So you should compare the results with the original trial, not with the new TNF inhibitor trials. And you see again 40% response in around 50% of patients. So that's practically what we are seeing with all the drugs that we have currently. Now, the interesting thing here is, if you have TNF inhibitor, fail a TNF inhibitor, there is still a significantly better chance of responding to this drug compared to a placebo. So again, good news, we have one more agent that we can use even if you have failed a previous biologic. Okay, so radiographic progression is one of the most important things apart from the inflammation and the symptoms in patients with ankylosing spondylitis. So this is an example of a patient who has gone on to progress to fusion. So initially there was just fusion in one discal vertebral segment here, vertebral unit here, and later on going on to fuse here. The good part of the story is that less than 20% of people actually go on to fuse like that. Okay, it's a very small percentage of patients who actually go on to fuse. The vast majority of patients don't have significant fusion. Now, in those 20%, is there something in our treatment modality that we can use to prevent this from happening? So the original studies were with anti-inflammatories. This was promising. So in this particular study, celecoxib was used on demand versus a group of patients who took it daily, twice a day. And at the end of 2 years, this was the rate of progression if you took it on demand, lower progression if it was taken every day. So it was sort of promising. We thought that, okay, maybe taking anti-inflammatories on a regular basis could be disease modifying. Now, after that more recently came this study. This was with the different anti-inflammatories. So it was again diclofenac continuous versus on demand, just exactly like the previous study. You see here at baseline and 2-year follow-up, around 60 patients in each group completed the study. And you'll see that those patients who took daily diclofenac had almost double the amount of diclofenac compared to the other group. And these are the results, essentially overlapping in most of the trajectory here. And there was no difference between those patients who were daily on an anti-inflammatory versus those who didn't take it. So the current state of understanding is that if you're doing well on a biologic, you don't need to keep taking an anti-inflammatory to prevent progression. But if you need it if you're symptomatic and need it, yes, patients should be on regular anti-inflammatories rather than being on demand. So essentially, there is no disease-modifying potential for this drug. How about TNF inhibitors? So we did the first study actually looking at this in a large scale, looking at 5 centers across North America. We had around over 300 patients in this study. And based on our definition, around a third of patients progressed. Now the question is, are patients who were in this particular part of the pie chart, those who progressed, did they get less amount of TNF inhibitors compared to those who did not progress? Maybe TNF inhibitors are preventing them from progressing. So here is a chart looking at regression analysis when you add every factor in the patient together. I'll just highlight these two. If the patients had damage at baseline, they are more likely to progress. If there was evidence of inflammation, more likely to progress. Patients who smoked, much more likely to progress. And if the patients used TNF inhibitors, 50% lower risk of progression. So this was probably the first study to show that there's a significant benefit of using TNF inhibitors to prevent progression. And we did it in different ways. The statistical analysis, it gave exactly the same results, around 50% decrease in risk of progression. Again, going back to the window of opportunity question, we talked about starting early, better chance of remission. Starting early, better chance of stopping the drug in the future. Now, the results of this study show that if you start early, there's a much higher chance of preventing progression compared to when you start much later. So again, one more reason to start treatment earlier. So another way to look at this data is, so blue dots, each dot represents one patient. So the blue dots represent patients who started the drug after 10 years. The red dots represent patients who started the drug much earlier. You see that those who started late, 60% progressed. Those who started early, only 20% progressed. So again, showing the window of opportunity. So the conclusions essentially are TNF inhibitors can be disease modifying, especially if you start the drug early. How about interleukin-17? This is more recent in clinical use, so we don't have direct controlled trials yet. There was one study which was presented at the last conference, and it was a comparison of interleukin-17 versus an anti-inflammatory, but there were 2 different studies. They were trying to compare it to each other, so it is not a head-to-head trial, and that didn't show much of a difference. But at least the animal studies show that it is promising. This is an example from a rat which has the rat model of spondyloarthritis. You will see that there is significant new bone formation on the surface of the bone, and there is loss of bone within, so osteoporosis within. And if you treat these patients with antibodies against interleukin-17, you see that the new bone formation does not happen, and in fact the osteoporosis is much better. The density of the bone within is much better. So there is potential. We are waiting for results. Just to summarize, we talked about the new ACR guidelines. You should be able to see them in print soon. We talked about early diagnosis and the window of opportunity. We talked about disease modification, and also we talked about the new interleukin-17 inhibitors. And that's all I have for today. Thank you very much.